The first time that we saw a surge in patients, we had information from Italy, we had information from the West Coast, we had information from China, but it was moving very quickly. We didn't have therapeutics for sure. We didn't even have clear guidance around how best to use oxygen therapy, whether to intubate late or to intubate early. Things this time are different. The population is much more educated about the disease. We are not telling people necessarily to stay home if they need care. People are getting tested as outpatients. And frankly, we're seeing a lot of people who are coming to the hospital after having tested positive, talking with their doctor, who know that they are now on the cusp of perhaps needing to be admitted to the hospital or needing interventions that you can only get at the hospital. Early on, one of the faculty members at Mount Sinai really changed the game for us by creating a highly sensitive test for COVID. So there's a lot of recognition early on that having clarity around who had the disease allowed us to manage them differently by very strategically and intentionally cohorting them in the inpatient space. Another big change for us has been the recognition about the degree to which the COVID changes people's risk of blood clotting disorders. Something that, again, early in the course, in the disease course, and in the surge last time, we just were not on the lookout for as quickly as we are this time.
In the very beginning of the first wave, we saw a lot of people who were staying away from the emergency department for fear of COVID. We've gotten back to some element of normality where patients seem to be presenting themselves for care for the whole myriad of things that may go on with their disease, or a chief complaint of chest pain or being short of breath. And so we don't find ourselves, I think, behind the 8 ball as much with patients who have delayed their care. You know, I think the fall wave patients would be distinguished by at least not appearing out front as ill as they seem to be in the first wave. They seem to have some degree of milder illness. The ones who end up having COVID in the first wave, we found ourselves doing a lot of very critical care medicine. There are a few more things in our armamentarium. I think that for us on the kind of front line in the emergency department, we're still concerned with what we like to think of as stabilizing the patient, making sure they're on enough oxygen, making sure if there's blood pressure support needed that we do that. But, you know, we now know that on the inpatient side, once we admit patients to the hospital, we have possibly convalescent plasma, remdesivir. Our infectious disease doctors are looking at the utility of various different combinations of antibiotics and the effect they might have. A number of my colleagues have actually published a paper that this goes back to the beginning of COVID, that they actually instituted some protocols to actually address keeping the healthcare workers safe while they were actually doing cardiac resuscitations or code blue patients. So measures that would allow us to effectively do all the things we do with CPR and advanced cardiac life support, even in the realm of having to keep ourselves safe from aerosolization and things like that when we intubate patients. So I think that was a bit of a landmark thing to develop ways that we could be as safe as we could early on when we were intervening on the very, very sickest of the COVID patients.
We were, as well as the rest of the world, were really building the plane while we were flying the plane, was our popular expression at that point. In the very beginning, we just did not have the data yet, and so we were enrolling patients in trials, and yet nobody really understood what was going to be effective or not effective in patient care at that point. We are fortunate in the Northwest right now, or in my city right now, to have a fairly low incident rate of COVID patients. However, our numbers are rising. The patients we are seeing in the fall wave as compared to the earlier wave have tended to be higher acuity from a medical or surgical perspective, but not necessarily higher acuity from a COVID perspective. My institution is seeing all-time highs in case mix index and general severity of index. On a regional and state level, we have created a resource out of our institution to help level load our entire state, knowing and understanding the virus has attacks certain areas or certain regions, certain facilities with outbreaks. Our institution in Seattle has been extraordinarily focused on the population of people who have been both disproportionately impacted as well as people who are kind of living on the margins. And so we have been very intentional about testing in those populations and addressing those populations and communicating with those populations, which I think is very unique, and I'm quite proud of our institution for focusing on.
What we're seeing in the initial part of the fall wave is a shift in the demographics to younger patients. We still see a number of the same comorbidities that we saw earlier in the pandemic in terms of obesity, diabetes, and hypertension, but certainly a shift toward a younger demographic. So one of the benefits with preparing for this wave compared with the earlier surge that we saw in the spring is, of course, that we've done it before. And so we have an infrastructure, or at least a framework, to try to think about how we prepare. And we, along with many other medical centers, have organized our preparedness around kind of 3 S words. So staff, space, and stuff. Staff, of course, is not just the critical care practitioners and infectious diseases providers and other physicians, but also nursing staff, respiratory therapists, and all of the other allied health professionals that are key in providing optimal care of patients with COVID. We're also keeping a keen eye on our space resources. So what are the available ICU bed available resources? Where can we expand? And we learned a lot during the first wave about the opportunities to expand into our ICUs, but maintain the environmental controls, the airflow patterns and such that are required to care for patients with COVID. And then finally, in terms of stuff, this is what we think about in terms of PPE, in terms of ventilators, bronchoscopes, the other equipment that we need to take care of patients with COVID, and maintaining supply lines that were secured initially during those early phases of the spring. But we have certainly learned a number of things that are beneficial, and importantly, a number of things that are not beneficial. So certainly data on medications like hydroxychloroquine have been universally negative or even trended toward harm. On the other hand, we have a clear signal for dexamethasone or steroid medications providing benefit in select patients with respiratory failure associated with COVID. In our view, the bedrock of care of patients with COVID-19 remains standard critical care. So this means meticulous attention to preventing complications, to providing organ support, including support for respiratory failure. At Northwestern, particularly in the ICU, I think that we are leaders in the use of lower respiratory tract sampling in the form of bronchoalveolar lavage to provide an early diagnosis or an exclusion of bacterial infection that can really help, in the former case, tailor, or in the latter case, limit our use of antibiotics and provide enhanced antibiotic stewardship for large numbers of COVID-19 patients.
We were flying blind at the outset nationally. Here in the Cleveland area, no different. We're seeing a bit of a difference in the type of patients between the first wave and the second wave. We're seeing sort of a broader picture of variability with disease presentation. We're seeing everything from completely asymptomatic to the very sick. What we're seeing now is a bit more of an insidious presentation, and part of that may have to do with the early phase of the infection. We saw a higher construct and concentration in urban centers, and we're seeing a lot more spread now into the rural and the suburban areas. We know now so much more about the risk of asymptomatic presentation, and we've all experienced this in our emergency departments nationwide, seeing the young person who comes in with a completely unrelated complaint and is found to be positive for COVID. Be that as it is, that higher index of suspicion, I think, prepares us best as we move into this fall wave. We now know what to look for, and we know what works and we know what doesn't work, at least with some semblance of certainty. We have done a lot of work here to identify that masks work and social distancing works. We know particularly that early intubation probably isn't the right thing for the patient, depending on how bad they are when they present to you, and trials of things like proning and high flow oxygen via nasal cannula have probably benefited patients in the long term. One of the other novel things that we've done at university hospitals that has benefited us is identification of COVID positive or COVID likely patients who are in a moderate risk category, but otherwise have stable vital signs, and sending them home on novel monitoring. We've partnered with a company called Masimo, which utilizes disposable pulse oximetry, respiratory rate, and heart rate that transmits 24 hours a day via Bluetooth and their phone, and we monitor them for the duration of their early phase illness, which has been instrumental in preventing and identifying their decompensations at home. It has been wildly successful, such that we are looking to expand it into other disease processes.
Early on in that, in quotes, first wave, or in the first few months, people were very fearful and anxious. People were coming home and washing their food with bleach. What we're seeing now is a large group of people that are very accepting and complacent, almost resigned to the fact that I'll probably get exposed, it's probably not that bad. We're seeing another group of people that, I don't want to call them arrogant, but they're really rejecting science. They're almost militant in their desire to show off that they are not going to wear a mask and they're not going to get sick. And some of them do. Early on, there was a scramble to be sure we had the right equipment, the right number of ventilators, we had rooms reserved. Now there's more contingency planning, and it's based on the days and weeks preceding today. What's it like going to be tomorrow based on today and last week? And we're better able to do predicting, and so we're much less likely to be surprised. Early on, we were very aggressive in doing CT scanning to see who was progressing and who isn't. We now reserve CT scanning for people who are decompensating. Unless there's a very specific indication, we don't do a lot of advanced imaging. We follow oxygenation, pulse, mental status, and we don't go to CT scan unless we have to, based on how the patient is not progressing or worsening.
So during our first wave of COVID-19, this was in May and July, when we had our waves in Virginia, what we found is that we did not locally experience a large surge in patients, which was, thankful for us. But certainly areas that were north and to the east of us in Richmond and the Northern Virginia area, we're seeing large influxes of cases, and many hospitals were overwhelmed. And so it evolved that our role became as kind of a release valve for these hospitals that were really overwhelmed with patients and needed to transfer some of their active cases to us. Our second wave in Virginia has not arrived yet, thankfully, but we're going into cold and flu season. And so we have to be mindful of patients who come in with respiratory illnesses that could be consistent with either, and thinking about the best way to test, treat, and triage these patients. One thing that we are doing at UVA is we're developing or bringing online soon a multiplex test that will be able to test for both influenza and COVID-19 at the same time through PCR, a rapid test. And this will allow us to at least figure out if the patient has one or the other or neither, and how to appropriately take care of these patients, because we do expect with cold and flu season, I think any sniffle, any cold or cough is going to have to be treated as one or the other until proven otherwise. And so that could potentially put a strain on our testing capacity. So that's one major difference. Another one is that we're trying to prepare other areas of the hospital for taking care of specialty patients. For example, on the OB-GYN service a couple of days ago, we actually admitted our first patient with active COVID-19 to the OB service. The reason is we don't want to necessarily isolate everyone to one specific area of the hospital, because we do want to be prepared for an eventual spike and wave and having our potentially having resources overwhelmed.